No, not a problem, not a problem. Okay, well, good morning. I'm Casey Bachison. It's good to be here. Thanks for the invitation to speak today. They asked me to talk a little bit about just what's new in my specialty, and that's I'm an orthopedic spine surgeon. So there's lots of new things that are going on in spine surgery. I could spend all day talking about all the kind of wild and crazy and fun new things that are coming around from a spine surgery standpoint. But I tried to, sorry there. Okay, you hear me better? All right, it sounds better. But tried to dial it down to just a handful of 3 or 4 of the things that we're using quite a bit right now that are different from what we were doing, say, 5 or 6 years ago. I just hit the green button. Maybe the battery's dead. We need the, oh, there we go. Oh, no, now it's clicking through all of them. Okay, there we go. Sorry, okay. So just to start the disclosures slide here, no conflicts of interest, stocks, commercial relationships, board appointments, consulting agreements, golf trips, or free lunches. And then the official statement here, I have really no disclosures. This is a quick slide I try and plug into any talk I'm giving just because everybody's always kind of curious about who's giving the talk and who they are and where they came from. I'm a local guy. These are all the schools I've attended. Weber High, Weber State, the George Washington University, and then I did my residency at the University of Colorado and at Henry Ford Hospital in Michigan, and then finally the spine surgery fellowship at the William Beaumont Hospital in Royal Oak, Michigan as well. Today I practice at Intermountain Orthopedics and Sports Medicine. So this is the rebranding of the Carlton Harrison Clinic, and so I practice with all of these incredible physicians here: Jeff Harrison, Neil Callister, Nick Goucher, myself, Todd Grunander, Terry Finlayson, Sean Keene, Brady Mock, and then we've got, I don't know, it seems like our PA is getting more and more every year. So, but I feel super fortunate to practice with this great group of guys. So the objectives for today, first and foremost, while we're talking about new technologies in spine, it's important to remember that for the most part, the basics are the same. They haven't changed, and they probably won't change for a long time. We do things a little different, but with spine surgery especially, there's some basic principles that you got to follow, and if you break them, people have bad outcomes. And so the basics for spines are always going to remain the same. We're going to talk a little bit about some changes to non-operative care, some options that we have now for treating patients with things like degenerative disc disease, and then some minimally invasive techniques that we see coming up more and more that help us kind of speed up the patient's recovery and have a little bit better outcome. So these are the basics. If you really dial it down to into a nutshell, spine surgeons really do 2 things, and that is we decompress nerves that are pinched. So if you've got a pinched nerve, we can help you. Or if you're unstable, we can help you. So if you've got a scoliosis or a spondylolisthesis, some sort of instability in your spine, we can put hardware in there, screws and rods, and stabilize it. And those are the basics of spine surgery. And when we get outside of that realm of trying to help somebody that doesn't have an instability or doesn't have some sort of sciatica or nerve root impingement, that's where we get into muddy water, and our outcomes then become quite unpredictable. So those are the basics, and those are the things I was saying that really haven't changed a whole lot. From a stabilization standpoint, it's usually instability that's due to, like I mentioned, scoliosis or spondylolisthesis, some sort of deformity, an infection, a tumor. And then spondylolisthesis, which really is still to this day, is the largest or most common reason for patients to undergo arthrodesis or fusion of their back, is because of this instability where one bone's sliding forward on another, and that ends up causing a lot of back pain and then pinching nerve roots. So from a non-operative standpoint, any patient coming into the office with sciatica or back pain, instability, they all go through these kind of 3 stages of non-operative care. And that involves medications, whether that's anti-inflammatories, muscle relaxers, nerve modulators. They're typically given some form of physical therapy or chiropractic care. And then we try injection therapy prior to moving on to any sort of surgical intervention. And the injections can be epidurals. That's probably the most common type of non-operative procedure that's done. Another procedure called a medial branch block or a radiofrequency ablation. And this is a procedure that's done for patients that have severe arthritis in their facet joints on the backside of their spine. So they hurt with extension. As their discs collapse, those facet joints on the backside of the spine start to develop a little arthritis and some bone spurring, and then that ends up causing them some discomfort when they're standing up straight or leaning backwards. And so that particular injection helps to alleviate some of the pain from that arthritis. And then finally, and this is the one I want to spend a little time talking about, is this basivertebral nerve ablation. And this is a fairly new and promising treatment for the treatment of degenerative disc disease. And the trouble with degenerative disc disease is this is the middle-aged man syndrome. You see it in women too, but this is the guy that's 45 or 50, sometimes getting into their 60s. But they've been working hard their whole life, and their discs are wearing out. And most of the time, as discs wear out, they do so squarely. So you just have this square collapse of the disc, and that can generate back pain. But if we look back to the basics I was talking about earlier, that back pain is very seldom associated with an instability, and it's very seldom associated with a sciatica. And so you've got this group of patients with this horrible back pain and these degenerated discs, but they don't meet any of the criteria where a spine surgeon can do anything to help them, right? There's no nerve that's pinched, and there's no instability. So those things that are good predictors of good outcomes in spine surgery don't exist in this group of patients. So they've become very challenging to treat historically. Just a little slide here to show kind of a healthy spine on the left, and then what a degenerative disc disease looks like on the right. And I guess I kind of picked the worst of the worst as far as the degenerative discs look on the right there. But if you look at the cut on the left, all of those discs have a pretty decent size height to them. And if you really, really scrutinize the discs, they've kind of got a white ring on the outside of the disc and then a white core. And that's the telltale signs of a healthy disc, is that it's hydrated. So it's got good water content to it, and on an MRI scan will show up bright white like these do. Now, as a disc degenerates, it starts to lose that watery core, right? And so that white core that you see inside the disc starts to disappear. And then they end up with these black discs that don't have any color to them. And then, so that's kind of the first signs of a degenerative disc, is the changing of the color. And then as the color changes, then they begin to collapse, and you'll see the loss of height that comes with degenerative disc disease. And it's typically treated with these options here, which is physical therapy, NSAIDs. And then if people are really miserable, the only option we've really had at that point is if they come to a point in their life where they just can't function. Occasionally they're offered fusion surgeries, right? And again, this is where you get outside the norms of what we know works, right? And so patients that are getting fusions for degenerative disc disease have kind of a 50-50 outcome. It's really hard to predict which ones are going to get better and which ones won't. And if you look at this slide here on the right, where there's degenerative disc disease at all 4 levels of this, all 4 or 5 levels of this guy's spine, the big question and the conundrum with a patient like this is, where do you start and where do you stop, right? Are you going to fuse all 4 of those, or are you just going to take a guess at which one's the biggest pain generator and try and fuse that one? And it's that scenario where fusions for degenerative disc disease become challenging, and where we kind of lose the predictability of our outcomes. This is just a slide showing, again, what are called modic changes, which is how we look at degenerative disc disease on an MRI scan. It's just the color change. So if you look at this slide here on the right, you can see those kind of white markings, the white, right next to the disc. Inside the bone itself are these white color changes within the disc. And so what happens as that disc degenerates, it gets little cracks in it, and then it releases some pro-inflammatory cytokines or chemicals that then irritate the bone, and the bone takes on this white-looking color to it. So there's a nerve inside this bone. It's called the basivertebral nerve, and this is a diagram of this nerve here. It enters the spine through the posterior wall. And then as it enters the spine, it has a ganglion there in the center of the bone, and then it branches upward and then branches downward and gives the spine, basically the pain receptors or the sensory receptors of the spinal M plates their innervation. And so the theory with the procedure that we'll talk about here a little bit is that if we could knock out that nerve, above and below a disc that's degenerated, we could potentially get rid of a lot of this back pain associated with degenerative disc disease. And so this is just a cartoon or some sketches of what's done. So the patient, this is usually done in the operating room. So while we call this non-operative treatment, it's still kind of done under general anesthesia because it's a bit uncomfortable. But the patient's put to sleep, and then using fluoroscopy, a small needle or a cannula is introduced into the spine down through the pedicle. And that's what you see on the top left here, is just this needle or cannula being introduced into the bone itself. And then through that cannula is a small wand that can be passed down and has a little crook or curve on the end that allows us to really target that probe right onto that basivertebral nerve. And then the probe itself has an electrode or several electrodes on it that allow us to perform an ablation of that nerve so that we can heat that nerve up and over a period of 15 or 20 minutes we can burn this nerve, and then it quits sending signals to your brain and to your central nervous system that you have pain. And so if someone, say, has a degenerative disc disease at L4-5, this is a procedure that you can go in. You have to put a probe at L4, and you also have to put a probe at L5, because you've got to knock out the bone above it, and you've got to knock out the bone below it. But in the process of doing that, you can alleviate a lot of the pain and discomfort from a patient's degenerative disc disease. So these are the outcomes, and they're actually fairly promising. There's a randomized controlled trial of 140 patients that were getting this basivertebral nerve ablation versus conservative treatment. And at 3 months, the basivertebral nerve group showed a 20-point decrease in their ODI score. So this is huge. And at 12 months, showed a 25-point decrease in their ODI score. The outcomes were actually so good, they started to allow crossover. So they started to allow, at a year's time, they started to allow patients in this conservative management group to swing over and receive the basivertebral nerve ablation. And even after a year of conservative treatment, this crossover group also was found to have a 25% or 25-point decrease in their ODI score. So this is really promising data. And also of note, I don't think I have it in my slides here. This is a procedure that seems to work better than the radiofrequency ablation that's done on the back side of the spine. The facet blocks that are done on the back of the spine, typically patients are going to have improvement, some sort of moderate improvement, 60, 70% improvement in their back pain, usually about a year's worth of time, a year to 18 months of improvement in their back pain. The long-term outcomes on this procedure, they're still kind of rolling in because it's, like I said, still fairly new. but shows this 25-point decrease in the ODI out to 6 years. So these are patients that are quite happy with their outcome. Want to talk a little bit, this is a procedure, kind of an up-and-coming or new procedure that's being done called a lateral lumbar fusion or lateral interbody fusion. And this is a procedure that it's been around for a long time, but really has reached its maximum potential, or the best potential it's had in recent years, due to just some retraction options that we have. And so this is a procedure where we can go in through a 3 or 4 centimeter incision on your flank using this plane that I've got on the right-hand side there, where you make this little opening on the flank and then kind of push all of the viscera anteriorly and kind of hug that retroperitoneal space, and you can access the side of the spine through this retroperitoneal space. And then just use this long, skinny retractor that splits the psoas and allows you really good access to the intervertebral disc. And the benefit of this particular procedure is that you can see the whole side of the disc and you don't have any of the spinal elements in the way. So traditionally, if we were doing fusions, we'd split your back muscles, put some screws into your back, expose this, do a laminectomy, expose the spinal canal, and then we try and put something in your disc space, because as these discs collapse, they narrow the foramen or the little holes on the sides of the spine. And so if you can put something in between these bones, you can open up those foramen, and that aids in the decompression of the spine. But we were really limited going from the back because you have to work around the spinal cord and the nerve roots. And so you really have about a 13 or 15 millimeter space to work through, and you're fairly limited with the size of the cage you can put in. And so the advent of this procedure here, this lateral interbody fusion, it allows you full access to the disc without any interruption with the spinal cord or the nerve roots. So you can put a very long, very large cage. You can put a cage up to 18 millimeters in height. You can put a cage that goes the entire length of the bone. So your ability to restore the height of the neuroforamen is significantly increased. So this is a procedure where through a very small incision, we can restore the height of the intervertebral disc to the point where oftentimes we don't have to perform a laminectomy. It opens the spinal canal so much that you don't have to then go in and decompress the spine or trim out the bone spurs inside the spinal canal, because just restoring that height actually creates enough space that the patients don't need it. So the typical approach nowadays is to go in, do this lateral interbody fusion, and then put some screws into their back through percutaneous holes, so you don't have to strip their paraspinal muscles. And most folks will do fairly well. If they still have a bone spur impinging on their nerve, you can go back a month or 2 months later and do a very limited laminectomy just to take out that one bone spur that might be bothering them still. But much less morbidity associated with this procedure. And so this is just some x-rays. This is actually a patient that's had 2 types of cages. And down there on this right-hand column, you can see there's some little wire-looking things in the middle of the bone. And then there's these very long cages that go left to right or right to left. And that just shows you the size of that spacer that can be placed there. It covers the entire end plate. It allows us to create a very large space for all those nerves. Okay, and then finally, kind of the last exciting thing we have is this sacroiliac joint arthrodesis. And this is another condition in the spine that is somewhat poorly treated. And the issue with the sacroiliac joint is you wouldn't think of it as something that is problematic very often, and you really don't run into patients that have it commonly, unless you're a spine surgeon doing a lot of deformity surgery. And so this is a problem of our own making to some extent, but what tends to happen in patients with long spinal fusions, if they've had a fusion as a child for scoliosis, or even as an adult, this long fusion of their spine over time tends to put a lot of torque on levels above it or below it. and anyone that's been fused down to their pelvis or their sacrum, the next most mobile joint in their along that chain is the SI joint. And so we see this SI joint breaking down and becoming very arthritic. And traditionally, this was hard to treat because there's no good way of getting to it, right? It's buried under in the way of the SI joint. If you're going from the back, you've got your glute, then you've got your pelvis, and then you've got your SI joint underneath that. And there was no way of really getting down to the SI joint without doing some sort of massive muscle dissection. And so there was a lot of morbidity and pain associated with that procedure because you'd have to strip all the paraspinal muscles off, and you'd have to, use some sort of curette to scrape out all the cartilage in the joint, pack some bone in there, and patients really are quite miserable with this procedure. So this is just a CAT scan kind of showing the sclerosis of those SI joints. So as patients with long spinal fusions develop a bad sacroiliitis or sacroiliac inflammation, they develop these very white, you can see here along the margins of the SI joint, the white sclerotic bones where the cartilage is worn out, and the patients are pretty miserable from this. So there's a new, fairly new, it's been out about 10 years, but gaining in popularity, procedures for fusions of the SI joint. And this is technology that really came out of the hip and knee implant world, where if someone has a hip implant, for the last 30 years we've been placing porous metal cups into your pelvis. And then over the course of 2 or 3 months, your bone in your pelvis actually grows into this cup, so that metal cup in your hip has incorporated itself into your bone. So some very clever guy got the idea that if we made these little porous implants that we could either screw across or wedge across the SI joint, we could get this bony ingrowth into these porous implants, and we could obtain a fusion of your SI joint with a chunk of metal. Right? And the benefit of this surgery is that you can make a tiny 2-centimeter incision over the side of someone's hip, and then we just run a wire through your glute right down to the side of your SI joint, and tap that wire across your SI joint, and then we can drill a little hole across the SI joint and put one of these screws across that's made out of this porous metal. And then over the next 2 or 3 months, the metal or the bone just grows right into that metal and provides a solid, stable arthrodesis. So there's no longer micromotion across the SI joint. What you tend to see is you'll first get that metal ingrowth, and then over the course of a year's time, you'll start to see bony arthrodesis developing across the joint as well. And so here's a patient, just some x-rays of a patient that's had that particular, this implant's called an iFuse implant, and it's this triangular one that you see kind of the middle of the screen, this triangular metal implant. But the screw version of the implant's becoming more and more popular as well because it's able to put a little bit of compression across the joint. The metal implant or the triangular implant is kind of wedge-shaped from tip to tail. So as it goes in, it wedges itself into the bone but doesn't compress the joint, whereas the screw is able to actually provide, there's a differential thread. So if you look at the very tip, there's more thread at the tip than there is at the tail. So once it crosses the SI joint, those finer threads at the tip will actually pull that portion of the bone faster than the screws behind it. It'll compress that joint so you get a little more stable fusion. And then there's a bunch of other technologies coming out. A lot of robotics are being used these days, primarily for insertion of pedicle screws. So just patients receive a CT scan, it's put into a computer program, and then they've got these robots that you basically clamp to the bed, and they're just like a service arm. They've got 6 degrees of freedom, and they can just move themselves around the patient and basically just leave a tube there that you can drill through, but will line it up perfectly so you can put pedicle screws and instrumentation into someone's spine through very tiny access ports. And so that's gaining in popularity just because it's so much less trauma to a patient's spine. And then endoscopy is actually really taking off. So just like a shoulder scope or a knee scope, people are using arthroscopes to do spine surgery where we can go in and create a little working space with water and remove herniated discs or perform small laminectomies, that kind of thing, through these endoscopic methods. And that's it. Questions?
Well, thank you. That was quite enlightening. I had a question about the ablation.
Mm-hmm.
So are you doing that as the surgeon, or is that part of the team that's doing that? Who actually is providing that?
That goes both. So that's kind of one of the exciting things about it is that it can be done by a lot of different providers. So you see it actually, pain providers are performing this even more than surgeons are. It's picking up with surgeons just because I think it's new enough that there's pain providers that just don't do it. So sometimes it's hard to find someone to do it. But there's a number of pain providers in this. If you look at any of these websites, there's 20 or 30 guys in the state performing that procedure right now. And it's either anesthesiologist running a pain clinic or PM&R guy running a pain clinic or a spine surgeon.
Okay. Thank you.
Yeah.
Are there conditions that would disqualify somebody from receiving basovertebral?
Yeah, so they have to have an anatomy that's conducive to inserting the cannula into the bone. They have to have enough basically cushion or space around the nerve that it can be performed safely. So you need about 10 millimeters of space from the middle or where you anticipate you're going to put the end of that probe to the spinal canal. So if they've got congenital anomalies, short pedicles, that kind of thing, sometimes that's too close and it becomes dangerous. You don't want to, you wouldn't want to heat up the spinal canal or cause any sort of thermal injury to the nerve roots.
So, two questions. One, if you could speak to the difference between orthopedics versus neurosurgery, doing these surgery. I know you're orthopedics.
Mm-hmm.
And then the second is just access. It's tough to get patients in to see neurosurgery and orthopedics for back and neck surgery. I don't know if that's going to change or if that's a fixable problem, but it's tough sometimes to get patients.
So as far as the difference, I think as the world revolves, the difference between an orthopedic spine surgeon and a neurosurgeon are becoming less and less. It used to be kind of the traditional method. Then there's facilities in the country that still use this method, like the Leatherman Clinic in Kentucky still uses this method, where traditionally the neurosurgeon was the guy that did all the decompressions, and then the orthopedist was the guy that did all the fusions, the screws, the hardware. And so if you were doing a spinal fusion or a decompression and you needed both of those, you'd have both surgeons in the room doing those procedures. And I think over time, each one kind of figured out that they could do the job of the other. And so, if you look at, say, Dr. Winter's practice and my practice, we practice very similar. I think the major differences between a neurosurgeon and, say, an orthopedic surgeon would be if there's something intrathecal, or inside the dura, you've got an intradural tumor, the neurosurgeon is usually going to take care of that. If you have a very complex spinal deformity, that's usually going to be the orthopedist, just by nature of their training. The orthopedic training is usually, or it was kind of the advent of it anyway, was scoliosis. And so a lot of orthopedics is still looking at the biomechanics of the spine and how to rebuild the spine. So a very complex spinal deformity is almost always going to be done by the orthopedist, where an intradural procedure is going to be done by the neurosurgeon, or a combination of the two. And that's actually becoming very popular right now, is that many fellowships in the country are dual certifying their fellows. As they're coming out of fellowship, they'll spend 6 or 8 months working with the orthopedic division and another 4 or 5 months working with the neurosurgeon division. And so the facility I came out of, that's what we did. I spent 3 months doing neurosurgery and 9 months doing orthopedic complex reconstruction.
Especially because of the type of DME format we're for this time. I want to thank you. I've been doing pain management going on 30 years and seen many, many of your patients, and I want to thank you for your compassion, for your excellence, and for the very human way that you approach the work that you do, and that you have really good success ratios with the patients. Thank you.
Thank you. That's nice of you.
Casey, can you comment on artificial disc replacement in the lumbar spine?
So artificial disc replacement I'm going to comment first on the cervical spine. So artificial disc replacement in the cervical spine works really well and has really good outcomes. They've looked at nowadays. It was done initially to kind of preserve that adjacent segment. Everyone thought, if we can do this disc replacement, it's going to preserve our adjacent segment. And what they found over time is that it probably doesn't preserve the adjacent segment like we thought it would. People still have breakdown of that adjacent segment. But just the concept of preserving that motion sits very well with young patients, and it's pretty hard to, it's a hard pill to swallow to do an arthrodesis in a 30-year-old that blew out a disc. And so the disc replacement in the neck works really well and is very successful. If you look at quality adjusted life years, the arthrodesis comes out a little better because it's cheaper, right? The disc replacement is expensive, but long-term outcomes are the same as far as adjacent segment degeneration, quality of life, and patients' perception of pain and their function. The lumbar spine is different. It's hard to access. It's wrought with complication. With a disc replacement, it's done because you've either worn out the disc or you've blown out the disc. And as you do that tends to wreak havoc on the facet joints in the lumbar spine. And so patients with lumbar disc replacement oftentimes will, because of the morbidity of the approach, will auto-fuse the level anyway. So you see patients coming in, they're like, yeah, anyone that comes into the office and has a lumbar disc replacement and says they feel good, usually has a fusion at the level where the disc replacement was done. It's auto-fused on its own. And so they come in like, yeah, I feel great. I've had this for 10 years. You really get a CAT scan and they're fused. Otherwise, if they haven't fused, they tend to get really bad lumbar arthritis. And so they end up having a lot of back pain from the lumbar arthritis. So it goes through cycles. We go through cycles where we put them in for, 2 or 3 years, and then people start having bad outcomes. You spend 5 years taking them out, and then 5 years down the road, another cycle. So they're out there, they're available, but they're limited in number. And I don't put them in personally just because I don't think the data's there yet that we're going to see long-term benefits from it. Okay.